Okay. There's another similar study, the diffuse study.
Yeah.
It's quite similar to this one, but I haven't had chance to read that study yet. Anything particular different on that study to this study,
Yeah, very different.
Yeah.
Because this study, they tested a group of patients that's got mismatch between clinical disability and infarction volume. But in diffuse, they don't get clinical disability in diffuse, because when you do mismatch is a phrase that used to be used to describe the
symptom and
correlation, not the symptoms. Mismatch is imaging. So in these clinical trials, they use the mismatch between the symptoms and the image. But in fact, mismatch in 2012, 6 years ago, it is on perfusion image to describe the correlation between the penumbra area, that means the ischemic area, and the infarction area on the brain. So if you have a big, a large ischemic area on the brain, but a small infarction core, then this is the mismatch that you want.
I see.
So in the first trials, in these trials, they use mismatch between clinical symptoms and MRI to see, or CT perfusion to see with bad clinical situation and good image. That means a small core of infarction and a bad clinical condition. Then that's mismatch between that small infarction cannot cause that bad situation.
Yeah.
So so it is expected that if you open the artery, the ischemic part of the brain will recover, and it will recover the symptoms of the patient.
I see.
Yeah, and in diffuse, they use mismatch on images. That means they calculate the area of ischemic, and they calculate the area of infarction.
I see.
And that is kind of more objective compared to this.
I see. Yeah, I see.
Yes. So if in diffuse, if they have a large volume of ischemic area and a small volume of infarction, then they will go for treatment no matter how the clinical symptoms of a patient is, because the ischemic area will predict that if we don't treat, it may become infarct. And the infarction area is the area that we will not be able to save, even with the most even when we open the artery. So yes, the idea is to identify the area of the brain that we can save. So with diffuse, with that kind of mismatch, we can evaluate more of how much we can save of the brain. While on these trials, we can only predict partially that the patient may improve, but we cannot evaluate how much they may improve, because we don't know the area of ischemic that the brain is having.
I see.
Okay. Yes.
So seem like we with the diffuse study, one thing is more objective, that we don't base on the evaluations of the clinical doctor on the Ranskin scale.
On diffuse is kind of more exact.
More objective.
They have the volume of ischemic area. They have the volume of infarction area. So it's kind of more objective. It's more and more accurate compared to just clinical data. But again, it is less practical to countries like ours, because in order to evaluate the volume of ischemic area and infarction area, you have to have the very good software, which is very expensive. Yes.
Wow.
Yes. Yeah, because that is the work of software. That is not the work of physicians like us to evaluate those kind of data. You see? So with our condition, it is we can do we can have mismatch between clinical data and infarction because it's easy. On MRI, you can see infarction area, and on clinical, you can evaluate the patient. Yes. Wow. But in order to do as diffuse is doing, we have to have the software, which will cost us a lot.
I see.
So that is why they have different ways to evaluate on clinical trials like this, because this is more practical, while the other one is more accurate.
I see. But one more question before we give the the microphone back to Huong. Yeah. So with the diffuse, so we kind of like, is it right to say that we don't really worry about the timing anymore? If we see the mismatch on the MRI, if it's a huge mismatch, we still go ahead, no matter what that is 24 hours or 36 hours. Is that right? I'm just curious.
Yeah. Now this has been debated all over in 10 years, not just 1 or 2 years up to now, because we know that each patient will have different different anatomy, because the brain will not survive 1 hour without any blood coming to it. It will not survive several minutes, you see. So in order to have the patient's brain survive for 6 hours, it's got to be blood from all the arteries to come. That is, yes. So each patient has different anatomy. It's got different connections in the brain. So 6 hours is used for 90% of the population. But when we use 6 hours, or when we use 24 hours, we are having another 10% of patients that can be treated, that can benefit from treatment. But we cannot treat them because we cannot identify them. You see that? So the anastomosis in the brain, the collateral, what we call it, the collateral blood flow, is more important than the time. The time is for us to use as a protocol to have our workflow fast, used for most of the patients. But we know that patients with good collaterals, we have longer time for us to save the brain. While patients with no collaterals, they don't have 1 hour for us. So there are patients that we treat in first 1 hour, but they do not recover, while there are patients who we treat in 8 hours and they recover. So the clinical trials are there to gradually identify the patients, which patient can we select that will benefit from treatment. And the reason why they have to do it again on mismatch is because the trials have failed in 2013. And it just gets successful again in 2015. So that is why now they are going to do mismatch. But mismatch has been used long ago, 10 years ago. And in the logic, mismatch is more important than time, because time is for the population, while a mismatch is for the patient itself. So if the patient's got a mismatch, if the patient's got a very good the whole area, the whole hemisphere that is ischemic, and a small part of infarction, and the patient is coming less than 24 hours, and the patient is having a gradually worsened clinical symptoms, then yes, this patient may be benefit from treatment even when they get out of 24 hours. You know that. We know that because it's logical, because it's logic, it's common sense. But now, in order to treat those patients, we will have to have trials to prove that those group of patients is worth treating. And know that when to avoid times, you see that way. And with these two trials, this will be pushed forward. We are developing countries. We practice based on what developed countries like America has been going through. But it doesn't mean that they in developed countries, they don't do everything based on the guidelines. Because if they do everything based on the guideline, we won't have the guidelines. You see that? Yes. So logically, we know that there will be patients that can be benefit from treatment, even when they're coming to the hospital after 24 hours. But we are not reaching there yet. We have to go step by step. We have to prove that the treatment is beneficial for patients less than 6 hours first. And the next step, as I predict 2 years ago, will be extended the time for treatment for a subgroup of patients, because in order to extend the time for treatment, we will have to select the patient more carefully, because if we use 24 hours for all the patients, we will treat patients that will not benefit from treatment, and we will have more hemorrhage. If we want to treat patients more than 24 hours, we will have to select the patients even more carefully. Yes, and that is the point. There will be patients that will have benefits with longer time of interval of treatment. But the problem is how to identify them. What is the criteria that we are using to identify them? That is also why they have diffuse. That is also why they want to have a very accurate evaluation. They don't want to evaluate vaguely based on the patient's disability. They want to evaluate very accurate based on the volume of the brain, based on what part of the brain is still functioning. You see?
I see.
Yes. So with this success, the limits will be pushed forward until we have a limit that we cannot pass. That is how. Yes, that is how medicine has been until now.
Yes. Progressing.
So yes, there will be patients that is still benefits even they come after 24 hours. But we are not going to do those patients until we have data. While in other big centers, for example, the centers that attend in these in these trials, push that, and we are waiting for them to push that. And when they have successfully pushed that, we will follow. That is how we practice here in Vietnam.
Okay, thank you, and Tuấn. We will talk more about this on the discussions. So let's restart. For those who just joined us, or for those who start watching part 2 of our journal club today. Today we are talking about the study evaluate the effect of the treatment for people who have stroke from 6 to 24 hours, like a delay stroke. This is the new study came out in November last year, and Huong Trần is the one who will continue the discussion today. Go ahead, Huong Trần.
Okay, thank you, Edmund. Actually, I'm quite interested in the discussion about the intervention and the mismatch, but I will hold it to the next part for discussion. Okay. Now let's come back to our presentation. Lately, we are discussing the definition of the clinical trials, and as I show you the definition from the National Institute of Health. So now I'd like to walk you through these 4 questions that they recommend to evaluate whether this is a clinical trial or a clinical research. Actually, this is quite interesting to me because I used to think that this is quite the same, but now we're going to discover what is the difference between the clinical trial and clinical research by answering the question whether this research design is considered a clinical trial.
Oh,
So
we cannot see your full screen over here.
full screen.
Yeah, can you see the slide, the full slide?
Do you see it now?
For some reason, the right part is missing.
Let me stop sharing and share it again.
Yeah, try it again and see. I don't know. Other people see the same thing? Just me.
Hello, everyone.
Okay.
Can you see the presentation on the screen?
Yeah, it's good now. Yeah.
Okay. So let's answer together those 4 questions. So surely that this study involved human participants. So for the first question, this is a yes. The second one, as you know, there's a 2 compared group, the one with thrombectomy plus standard care and the other one with just standard care alone. So yeah, this is an intervention in this study. So another yes for question 2. The next one is the study designed to evaluate the effect of the intervention on the participant. So well, as you know, the outcome of interest in this research is the disability and also the adverse outcome of that relate to the safety, which is maybe for example the on-cause mortality or stroke-related mortalities, something like that. So yeah, basically they want to affect they want to evaluate the effect of the thrombectomy group of the thrombectomy on the patient. So yes, for question number 3. The last one is the effect being evaluated a health-related biochemical, obviously, right? So based on the 4 guided questions from the NIH, you can say that this is considered clinical trials. So for clinical trials, they have to meet all of those criteria. And clinical research, maybe they miss some of those criteria. So that's the difference between the clinical trials and clinical research. If you want to have more examples or have more practice on case study on differentiating between those 2 kind of research, you can go to the website of the National Institute of Health, and they will give you a full definition as I show you last slide. Also, some of the case study that you can practice on to better understand the design, the research design. So talking about clinical trial designs, I also would like to introduce you some of the popular design in the clinical trial range, and it will have some relation to our research design, and let's go through together. So if we look at the comparison structure, like how they compare between groups, they will have 3 popular designs that you may be familiar with. The first is parallel. As the name says to you, they will have maybe 2 or more groups, and they allocate each group to different intervention to see the difference in effect in each group. So that is called parallel. So basically, the 2 group will be performed the intervention at the same time, and they will decide which patient belongs to which group at the beginning of the entry of the research entry. The crossover design. So basically, the thing that I want to measure here is the order. So they allocate one group of patients to intervention A first, then B. and they allocate other patients to other groups of intervention B first, then A. So they want to measure like some of the interaction between the two treatments, and also how the same patient will react to other treatments. And for the last one, the group allocation, so basically the name says it all. So in some situation, when the personal allocation of patient is impossible, for example, you want to have a behavioral intervention, like you want to change the educational program of one kindergarten. I mean, in kindergarten children. So maybe you cannot assign each of the child into the intervention, because basically they go to the same class and they have the same teacher who take care of them. So maybe you can't give another another intervention to each child in the same class, right? So they use the group allocation to allocate the same intervention to a group, and they compare other groups together in order to find the result they want to focus on. So it's talking from the comparison structural point of view. So when we dig deeper into the parallel design, so there's another two design, which is factorial and large symbol design. For factorial, basically you can imagine of this as they has two interventions to test at a time, and they do this for two main reasons. The first one, and the most popular reason, is it is an economical way to test the two different interventions at the same time. Another reason, which is very rare to see in the medical research, is they want to figure out the interaction between the two interventions. So that's just a very basic information about factorial, and you can dig deeper in the course material that I give you later if you want. Another design which has the parallel structure of comparison is the large symbol design. So basically you just imagine from the name that is a very large research which has a sample size of tens of thousands participants, and it has very simple criteria, simple intervention to perform, and simple assessment methods, so that they don't have to invest so much resources into training the researcher or to getting the measurement, getting the results they want. So the reason they want to do this symbol design, this large design, is they want to find out or to prove a very small size effect in some of the situation. Just imagine that, like if you have a very small improvement in some kind of cardiac intervention in patient with cardiovascular disease, but when you look at a public health perspective, and you can see that as a whole population, the benefit that your patient may have from the intervention is very considerable. So that small size effect will be very sensible to be proved, so that you can benefit your patients more. So that's the reason behind the large symbol design. And when we look at the research question, like I showed you before, we always want to know like which result the author expect to see, which is their hypothesis. And basically when we do the research, we always have the hypothesis that we want to prove, or we want to exclude it. We want to exclude it. So that is how testing hypothesis is about. So in many cases, we want to prove that the intervention A is better than intervention B, which is called a superiority design. So we want to basically want to prove that the experimental intervention is better, the current one. For equivalency, as the name may say to you, they want to prove that the two intervention has the same effect on patient. For non-inferiority design, they want to prove that the intervention that they want to test, at least they are not worse than the standard or the control group. So when they do this, they will, and if they can prove the equivalency, or they can prove the non-inferiority characteristic, they may bring into the market some cheaper or some more convenient intervention or treatment methods that will benefit the patient more. You can imagine of this design as a research which want to prove that a kind of treatment for asthma is as good as the current one, but the new treatment will just the patient just needs one time of using it a day, compared to the current one with 3 times a day. So it's more convenient for the patient. And if they can prove that the effect or the benefits of the new drugs is at least equivalent to the current one, so you can imagine that the patient will benefit for it a lot, right? And the last one I want to introduce to you is the adaptive design. So talking about a flexibility when you conduct a research, all of the researchers want to come up with a conclusion which they can prove that some effect, if they really exist, it will be proved by the result of the research. So basically, they will stand a margins of success when they conduct the research. So that's where comes the adaptive design. So if you look at our clinical trial, you can easily point out that this is a parallel design, right? They also test the superiority of the thrombectomy versus the standard care alone. And this is an adaptive design. And here I will go back to the design features of this clinical trial. As I mentioned before, this is a multi-center perspective, of course, because this is a clinical trial, so it have to be prospective. A randomized one, open label with blinded assessment of endpoints, and here you can see adaptive enrichment design feature here. So we will go through one by one, and I will give you a very brief explanation as to why this design is suitable for the research question here. So for randomization, in this research, they perform a central web-based procedure to allocate patients to each group to maintain a balanced ratio of 1:1 between the thrombectomy group and the control group. So they put it central here because, as you know, this is a multi-center research. So they have like a central committee who perform some of the administrative task, and also they ensure the they ensure the good implementation of the protocol in all of the centers. So here I show you a material from the course I mentioned on the Coursera, which give you a rationale for randomization here. So basically, when you talk about randomization, you think of a way to balance all of the features that may become the confounders to the research results, right? So this is also the rationale for using randomization as a very cool feature of clinical trials, because you can avoid the selection bias when you allocate patients to different intervention group, right? You don't want to be biased by the prognostic factors, like in this clinical trial, maybe the age or the time of interval may be a very important prognostic factors to the final outcome, and you don't want to favor a certain group of patients into this outcome. So you do the randomization to make sure that you balance the risk and the benefits that might present to all patients equally. So that's for the prognostic factors. And also maybe there are some confounders, some factors that may not be known or unknown to the researcher, and they just want to rule all of it out and to focus on just the effects that they want to test in this research. So for this research, they just want to limit the intervention into the inclusion criteria that they specify before, and they want to rule out all of the potential confounders, so they perform the randomization procedures. Another blinding is another important to clinical trials. As you may know, our psychology is very powerful, right? If you know something firsthand, it may affect the probability that you do another thing. So basically, that's the rationale behind the blinding techniques. So in this clinical trial, as you know, this involved surgical intervention. So for surgical intervention, they can't try to blind the patient, or they can't try to blind the physician about which intervention the patient received, because as you know, when the patient undergoes intervention, a surgical, they will have a very different follow-up procedures. So although they want to minimize biases by using blinding, but blinding is impossible in this case for this research. So in this research, they try to apply the assessor, the physician who assess the outcome of the patient, so that they try to minimize the bias, if any, that the physician might have in favor of one intervention to others. So you can imagine that one evaluating doctor who are not aware of the random assignment, they don't know whether this patient is belong to the thrombectomy group or belong to the standard care group, but they will do the assessment on the ranking score to see the disability level of the patient. So this somehow add more values into the objectivity of the result interpretation. Okay, this adaptive enrichment, the very new one to me, and I think that is also hopefully will interesting to you. So as I mentioned before, for the fixed design, They will define the sample size, the hypothesis of interest, the outcome they care about, and also the treatment. All of these features will be established before the trial starts. But for some reason, they want to use the adaptive design in which they specify some of the criteria that they may face in the research the research implementation. So if they meet that criteria during the research, they will switch or they will change some of the design feature in order to bring about a better chance of success, or to be able to see the effects, if there is any real effect. So for better illustration, this is the definition from the FDA that they define adaptive design is the prospectively planned opportunity for modification. So the basic difference here is you have to specify it first in your protocol before you actually collecting the data, so that you won't be affected by the data you see from the research when you change some of the features. So it's kind of to maintain the generalization and the objectivity of the research. And the modification will based on the analysis of the data in the study. So it is to differentiate between the adaptive design and the fixed one, because in almost all study with the fixed one, there may be some change during the research process in order to improve the efficiency, improve the chance of success, or to avoid the failure of reaching a significant result. But in fixed design, traditional design, they will not specify that first before they collect data. So that's the important difference between the two designs. So basically, you can look at the process like this. Okay. They will begin the data collection with initial allocation and sampling rule, just like any clinical trials. But when they analyze the available data, so they continue to recruit patient and they collect the patient. They collect the data. They will periodically assess whether they meet the stopping rule or not. So if no, they will continue to do the same process they plan in the protocol. But if they meet a stopping rule, they will stop the trial, or they begin the next phase in seamless design. So one of the reasons that they stop the trial is most popularly they can see from the existing data that one intervention group will have a very high, very significant harm or benefits compared to the other group. So they have to stop the research sooner than expected. That is the case in our clinical trial. And when you look at other possible way to adapt research design, there's many ways. But in this trial, I'd like you to focus on this section, which is the outcome tested. So as I mentioned before, this is trials that designed to recruit between 150 to 500 patients, but they have to stop when they recruit 206 patients due to the reason that they meet the stopping criteria. So as you can see here, the sample size pre-specified is 150 to 500. But the enrollment in the trial was stopped at 31 months when the result of the interim analysis, which is the analysis of the existing data in the research, meets the criterion, which is the probability of superiority of thrombectomy is more than 39% for the first primary outcome. Sort of, as you may remember, the first primary outcome here is the disability on the utility weighted ranking score of the patient at 90 days. So they are 95% sure that if you continue to do the research in this way, 95% that you will see superiority. I mean the better outcome in this group of patients, the thrombectomy group. So that's the reason why they want to stop the trial earlier than expected. And also, as they collect the data, they also want to change one outcome, which is initially is the secondary outcome. They want to change it to the primary outcome. So that's the adaptive features of this trial. The other techniques, which is called enrichment, is another tools to raise the to try to raise the success, the chance of success in research. And in this research, as you can see the illustration here, there's basically two stages. The first stages they will do as all other research do. They will enroll both patients in two groups. Here I call subpopulation 1 and subpopulation 2. In this research, it is thrombectomy group and the standard care group. And then when they continue to collect the data, they will make the decision if the treatment effect is strong in the combined population, which means that the treatment effect is balanced between the two subpopulations. They will continue to do the original plan. But if the treatment effect is strong in just one group, among the two groups, they will follow some adjustment in the enrollment process to enroll maybe more patients into subgroup 1 or to enroll just only subgroup 1 population. So that's the way they will gain more data in order to prove the effect one is a real effect. So it's like to add more power into their statistical techniques that they will perform later in the data analysis process. And alternative 2 is they stop the trial. Like in this clinical trial, they do stop it because they see really considerable benefits of patients who undergo the thrombectomy plus standard care compared to the standard care alone group. So you don't want to risk your patient more, right? So you want to give them the best, the proven clinical benefit that they may have. So that's the rationale behind this enrichment design. So if you think about this, do you have the question in mind that whether this adaptive or enrichment design they will somehow affect the objectivity or the effect size of the research results? Because to me, when we do a clinical research, when we do the randomization, we want to balance the benefits and the risk to different allocation group, right? So we want to be as objective as possible and to avoid any confounders or any biases that may come irregardless of we know it or we are aware of it or unaware of it. So we just want to be very logical. So do you think that these features of design will somehow affect the the objectivity of your results? Can anybody share me your thoughts about this?
Yeah, may I?
Yes.
Because I'm not an expert in doing clinical trials, but it seems that the way that I understand about adaptive and enrichment is different from you. It's kind of like this. If you do a clinical or randomized clinical trials without in a broad criteria, that means you have less criteria for the patients. The trial may fail because you are not focused on the group of patients that can be benefit from the treatment. You know that, right? There are some trials that may fail if you do it for many patients in a broad area of patients. For example, if they just got clinical dysfunction and infarction, but we cannot identify what is the mismatch that we want. We know that the patient with worse clinical situation and smaller infarction, we have a bigger mismatch, right? But what is the limit of mismatch that we want? What is the volume of infarction compared to the clinical data of the patient? Now, if we do not focus on that, if we run the trials on all the patients, this trial will fail, right? So how can we know that what subgroup of patients will be benefit from the treatment? Now, adaptive, it means that when you run the trials, you can change the way that you recruit the patient. You do not change the way that the patient is randomized. The patient is still randomized. But now, for example, after 10 pilot patients, after the first 10 patients, you run the analysis. You identify which kind of patient may be benefit from the treatment, and you change the criteria of recruiting the patient. It is not that you change the randomization. It is that you change the criteria of recruiting the patients, because now you focus on the subgroup of patients that may be benefit on treatment. You see that, right? So it's different. So it does not change. It may change the result of the trial, but it does not change in a way that is biased. It doesn't. It changes in the way that now we can focus on the subgroup of patients, on the population that can be benefit on treatment. So adaptive means you can change the criteria of recruiting patients during the time that you do the trials, because during the time that you do the trial, after the first several patients, you can identify more and more on what subgroup of patients will be benefit for treatment. You can do it in 2 stages. It used to be done in 2 stages. They have done trials on a very broad area of patients, and it failed. And from the data, they do subgroup analysis to identify which subgroup will be benefit from treatment, and they do the trial again on the subgroup. That is how it has been done before. So it is time consuming. It will have a failed trial before, which makes people think that the treatment is not effective and may kill the technique from the beginning. That is why they have this adaptive. You see that, right? Now you understand that. Because for example, if you do this for a large of patients, then the result will be failed. And there is not so many physicians that can do subgroup analysis there. When the result is failed, most of the physicians will know that this treatment is not effective, and it may kill the technique, and it may kill the treatment. from the beginning, because the trial does not focus on the group of patients that can benefit of that. It is not because the treatment is not effective. It is not effective if you use it on all patients, but it will be effective when you use it in a focused group of patients. And adaptive is there for you to identify the subgroup while you do the clinical trials, so that you does not kill the treatment with a failed result because you use the treatment not appropriately. So that's adaptive. Yes, adaptive helps you to identify the subgroup of patients during the time that you do that, during the time that you do the trial. So it changed the way. So it is good in two ways. It is good because now you're not harming the patients that were not effective with the treatment in the time that you do the trials first. And second, now it is easier for you to identify the subgroup of patients that will be benefit for the treatment. And you will have both identify the subgroup of patients, and second, prove that the treatment is effective in that subgroup of patients. So that's the meaning of adaptive. It does not cause bias. But yes, it does not cause bias because the patient is still randomized. But it just helps you to identify the subgroup that will benefit from the treatment, not the other groups of patients. You know that? Okay. Now enrichment. Enrichment is meant that there are as I remember, 3 ways of enrichment. But an enrichment is meant to have you have the answer with a smaller number of patients. Okay, so now you can either have enrichment by better identify the patients. It's called decrease the variability of the patients. That means the better you identify the patients, the better that you identify the population that you want to recruit, and the less variability that they have. And because the less variability of they have, the stronger the result will be. That is one kind of enrichment. The second way to enrich is to predict what kind of patient will be benefit from the treatment, and you recruit only those kind of patients.
Okay. So it's kind of I understand it is quite similar to adaptive design, right?
Yes.
Like you want to choose the more suitable patient groups.
Yes, but adaptive, that means you identify that and you change the criteria. Adaptive means that you change the criteria for recruitment during the time that you do the trial. And when you change the criteria, for example, the other slides, the slides that you have enrichment, they have the patient into subgroups, right? Okay, yeah. That subgroup is not the subgroup of treat and not treat. It's not that subgroup. The subgroup is, for example, the subgroup A, B, or C in this trial. The subgroup of patients that is more than 80 or less than 80. That's got higher needs and a little bit higher volume of infarction. That is the subgroup that I want to tell about. It's not the subgroup of doing the procedure or just standard care. That is not subgroup. That is, yes, yeah. So now you when you do adaptive, that means you predict what group of patient will benefit, and you recruit only that group of patients. That is enrichment. Enrichment is adaptive is to change the criteria based on the analysis you do with the previous patients. Enrichment means you recruit only the group of patients that you think will be benefit from the treatment. So it is adaptive enrichment because you adapt the criteria and you enrich the subgroup of patients. You only focus on the subgroup of patients that can be benefit for treatment based on the previous analysis on the previous patients. You see that? So enrichment also does not cause bias because enrichment only focus on the subgroup of patients. It is more focused, but it is still randomized. So if the patient meets the criteria of the enrichment group, then the treatment will be effective. You see that? So adaptive enrichment is there. Why is it there? It is there to shorten the time of trials, because trials takes time. When you do trials on a large group of patients, it will be more time consuming because you need more time to recruit patients first. It will be easier to fail because now you are applying the treatment for a large scale of patients, not focused on any specific condition of the patient. It is easier to fail. One, the treatment is effective logically. So if you think that that the treatment should be effective, then you do analysis because now you can analyze the patients. You can restructure the criteria for recruiting the patients based on your foretell what kind of patients will be effective. And you do enrichment to prove that what you think is right, that this group of patients will be benefit from treatment. So it is easier. It is not biased, but it will have more focused answer on what group of patients will be benefit on the treatment. You see, yes, and it avoid a false failure. I call it false failure because it's failed because we do it not right. We do it not on the right group of patients. It is not because the treatment is not effective. The treatment is effective, but it is failed because you do it on the wrong group of patients. So if you do a clinical trials and you do it in the wrong group of patients and it got a failing answer, it will be very damaging both for the treatment and for the group of patients that may benefit from that. So we have adaptive enrichment. So that is what I understand about this, because this technique is there because of that reason, you know. Okay.
Yeah. So thank you so much, Dr. Tuấn. Actually, when you explained to me this, you make me remember one of the very first step that we design research or we conduct a research is we have to make some kind of assumptions and the estimation based on the available data from other research to come up with the sample size or to design our research. So maybe those assumption and estimation is not exactly what we find on our population. So when we do the analysis, the data analysis during our research, maybe we'll find that the initial assumption or the initial estimation they considerably inaccurate with our population in interest. So yeah, so I can say now more clearer that why we need to adjust the adjust our estimation or adjust our subgroup the population of interest in order to have a larger sample size, in order to have which leads to the more successful chance or more power of the results. So that's what I get from your explanation.
Yeah,
but
I think
is it easy to understand? Is it what I explained? Is it easy to understand to all of you?
Yeah, I think it's I cannot speak for everybody, but I think it's just at least I can understand. So again, if two groups is well randomized, then there's no bias in that, so the result is is good. So there's nothing wrong about that. Adaptive, from what I understand, is that moving forward during the study, we look at the result and then we make adjustment. But but still, two groups still have similar patients, so there's no different in patient come to this group or that group, whether control group or intervention group, they still receive the same type of patients. But now these patients who recruit into the study will likely benefit from the treatment, so that we can see the effect much better, much faster, so that we don't keep recruiting patients with not going to benefit from the study. So yeah, of course, those who go to the control group will not benefit from the intervention, but yeah, that's why we do the study. But then it saves a lot more patients who, if we don't do the adaptive, they will go to the control group, and much more people won't get the benefit of the intervention. Yeah, so that is adaptive and enrichment. But this one question is that, yeah, for those subgroups have clearly benefit from the treatment, like for those with have large, yeah, difference between the symptoms and the infections. Then yeah, the larger, I guess, the more benefit the patient gonna have. But for those with a bit on the borderline, so those patients not getting recruited, they may have benefit too. But then if they not get into the study, is that we someone try our discussion. Yeah, is that if we're not recruiting the patient, those patients, then we don't have the good evidence to recommend treatment on those patients. Is that right? Yeah, if we not recruit patients kind of like borderline, then we don't know whether, yeah, we not study them, then we don't know whether the treatment is benefit for them or not. Oops, hello. Yeah, I don't know what I understand is correct or not. Hello there. Oh, it's missing some teeth. Oh, we have a new audience, this young audience here. Good.
Yeah.
Yeah, he's going to try us. Yeah, sorry, I take.
Hello, boy.
Hello.
Hello.
Hello. Good evening.
It's morning.
We're 9/11. Yeah. You guys speak English very good, and this is not a topic that I am very well about that. But my comment is I would like to see the slide with less word and clearer, which is means like what is the difference between two groups and what we can take home, because for my understanding for bibliography or something like that, when you read the whole articles with 1 or 2 pages, so you have to summarize in 1 or 2 or 3 take-home message. So what is your take-home message for me to bring home and to continue to work with that?
Yeah, yeah. I guess that's Huong will come to some take-home message, and we can come up together with some take-home message after we finish the discussions. Yeah, but good suggestions, yeah, Chị Loan. Yeah, and for the slide, yeah, if by some way we can make it into, yeah, less words, more bullet points, would be, yeah, nicer for those who follow, but sometimes maybe a bit difficult. Yeah, but yeah,
I'll work on it. Thank you.
Yeah, but I'm sorry, I also give you this project with very short time, so yeah. Okay, so yeah, I don't know, any of our audience have any questions regarding the adaptive enrichment, which, yeah, definitely something new that I never learned before reading this study, which is really, really interesting. Of course, I know that, yeah, we know that nowadays more and more study gets stopped early because of the benefit or the damage of the intervention. For example, the SPRINT study for high blood pressure, for example, they see that the benefit is quite significant, and so that they stopped the study early, so and publish the results early. So yeah, so that more people can benefit from the results rather than wait and have patient in the control group go without the benefit of the results. So that how seem like that how people doing study nowadays, and yeah, that's good for the patient. But again, I just wonder for those who's kept on the borderline, who get eliminated early because they when with just a few cases initially, they may not see the benefit yet, and they got eliminated already. They're not get recruited into the study. Then then we don't have enough data to see if there's benefit for those patients yet. But I guess yeah, that's the way we do study nowadays, and hopefully in the future some more studies focus on that borderline groups and see if they also benefit from the intervention.
I have a question. Although this adaptive enrichment design is very useful to reach your conclusion or to see the real effect, I just wonder that if we change the target population during one study, will it affect the way we interpret the data? Because clearly that if with the initial design, maybe we don't see very considerable effect size on days one, because we have some kind of unsuitable patient group that we collect data from. But when we change, maybe we change the inclusion criteria, and then we come up with a bigger effect size, a bigger benefits in some of the subgroup or in the intervention group. So it may give us more beautiful numbers and more beautiful data that we have a larger side effect. So when we combine all the data from the initial design and the adaptive one, it will somehow affect the size of the effect. So I just want to raise the question that why they don't stop the initial design and they continue with a new design, so that they will separate the two collection of the two collection of data, so we can see that. So we will be able to see the real effect size, like the how beneficial that the intervention is to patients.
Well, I think, again, this is what I think, and this is what I get when I talk to more experienced physicians all around. Adaptive is like combining the two steps of having a trial first, failed, and then having another trial on the subgroup of the first trial that you think will be benefit. That's kind of a two steps of that, you know. Adaptive, that means you can do the second trial without having to do the full first trial. That you get that, right? But the point is this: when you do adaptive, you have to have proof that your treatment is effective. You have to have proof that your treatment is effective. So when you have had proof that your treatment is effective yet, then you are allowed to do the adaptive, because now you want to identify the subgroup of patients that is more effective on the treatment. For example, on this, you have to identify the subgroup that can be benefits when you extend the time, the time for them. Okay, if you have a treatment that you don't know whether it is effective yet, then you have to do trials on all patients. You get that, right? So yes, it will get a bigger size effect, but because during the time that you do this, you also want to identify the subgroup of patients that is beneficial from the treatment. So the larger size, the larger size effect does not influence how you interpret the result of the treatment. Because after the adaptive enrichment trial, you come up with the result of the treatment and the subgroup of patients that will be benefit on the treatment together. You come up with those two factors, those two results, not only one result. You get that, right? So during the time that you do the trials, you will also identify the subgroup of patients that will be beneficial, will be benefit from the treatment, and you prove that the treatment is benefit for that subgroup of patients. So it's kind of, you do the two works at the same time. Mm-hmm. Yes. So it does not mean to change the way that you interpret that, because instead of doing the larger scale and then focus based on the data of the larger scale on the second trial, now we do it on the same trial, and it is structured to have very clear criteria when will you begin to change your criteria for recruitment. Because when will you think that larger scale will not be effective enough, and you focus on a smaller scale of subgroup of patients that will be effective. So it is designed for you to calculate, to run the simulation, to calculate, to predict what kind of patient will be beneficial from treatment. So yes, so it comes up with two results, not one. It does not come up with just whether the treatment is effective. It comes up also with what subgroup of patient will be beneficial from the treatment. So you have two answers for the treatment yourself. Mm-hmm. So, but first you have to prove that that treatment is at least not harmful yet, mm-hmm, before you do the adaptive. So that is why they don't do adaptive for the first trials to prove that intervention is effective. They don't do that for those patients. They have to get a failure first, and then they do it again with patients with a smaller time interval, 6 hours, and yes, and they have to be successful on that before they can do something like this. So with something like this means that we know that treatment is effective, but now we want to identify the subgroup that it is more effective. So that is what I understand from talking with the physician, especially the physicians that attend this kind of trials. So it is there for us to use, and when to use it, it depends on the background, on the situation, on how much we have progressed with that treatment or not. So I don't think that it will change the way that you interpret that. It doesn't change that whether it is effective or not. It doesn't change that. It just makes it clearer for us what subgroup of patients will be beneficial for that. But yes, as Dr. Minh said, because you have a small group of patients first to analyze, so you will reject the patients that you think from the first analysis that will not benefit from the treatment. So that is problematic, because the more focused we are, the more chance for us to reject patients that can be beneficial on that. and in vice versa, the more larger scale we do on patients, the less focused we are. That means we can treat patients that is not meant to treat. And the more focused we are, we may reject patients that is meant to treat. But that borderline is always vague. The borderline of which patient will be benefit from the treatment, it will not, it won't be clear. Forever, it won't be clear. So we can only try to have the data to get clearer, to get as clear as possible, to get clearer and clearer the criteria of choosing the patients. But we cannot avoid that. We cannot avoid having the patients that don't meant to be treated, but having patients that mean to be treated, but we fail to treat because we don't know whether it is effective to treat those patients.
Okay, thank you.
Yes, okay. So just some little point of here. So normally we don't focus a lot on the method of the study during the journal clubs, but because today I asked Huong Trần especially to talk a bit more about the method, so that our groups in general going to benefit from seeing what the methods may affect the results and how we should pay attention to the method to interpret the results. We are lucky that this study seminar is very well designed, and and also New England Journal of Medicine is also a quite respectable journal, so I guess that they don't publish any study that not very well criticized, and they don't publish studies that not really worth publishing. And so that's the study we can learn, and the results we can really, I think the results is kind of like changing the practice in medicines.
Yes.
Yeah. But still, sorry for those who just joined the journal club today and see that we're talking a lot about about the methods without discussing too much about the results. Then this is the second part of the discussions about the results of the study. And we are lucky that we have Dr. Tuấn with us today, who's doing hands-on and who've been following the trend of the treatment, and who have even more updated result. So normally for the medical community, we consider results from article is the most up-to-date, but specialists in the field like Dr. Tuấn Trần, going to conference, actually they learn the trend of the treatment even before it gets published for the popular medical community. So that's how we normally see new information come out in medicine. So Dr. Tuấn, any first-hand information or your practice that you can share with us?
Yes, I want to tell you that this is new, but this is not new because it has been done in big centers in Europe and in America for 5 years. So when the result, when the trials failed in 2013, everyone that is working in this field knows why it failed and knows that the treatment is effective, because in centers that they do enough cases, that is large enough, they still do what they are doing because they got their own data on patients on their own centers. And so that is why going to conferences, talking to them, help us to catch the trend of the field very easily. Not because we just need to learn from the experience. In 2015, when the trial was a success, and we begin to push again on intervention. They have been doing patients up to 24 hours. So this is not exactly new. It is new proven, but it is not, the practice is not new. In America, big centers have been treating the patients up to 24 hours. And because the treatment is more and more safe, and the way that we interpret with the techniques that we have, with software that we have, the machines that we have on imaging, it is more accurate for us to be able to validate what area of the brain can be saved and what area of the brain cannot be saved. So yeah, this is I used to think that when there is new change dramatically on guidelines, it is a bump, a sudden change, but in fact it is not. It is to use daily practice in big centers. Now it's been applied to smaller centers. It is not something that is dramatically changed, and that is also why, if you are in America, if you go in some field, does not wait for the guidelines, because if, as I tell you, if every one of us is doing as the guideline is telling us what to do, we won't have new guidelines. So new guidelines is there because logically we know that which kind of treatment can be effective, and we know that our job is to find the subgroup of patients, the right group of patients, that to apply that treatment or not. So our background, anatomy, physiology, logical common sense is very important to predict what kind of treatment will be effective on what group of patients to do trials. So trials is there, data is there. It's just to prove that to prove for the world, to prove, for example, for me to prove with the neurologist that this is effective. So let's do that. Trials is there for us from many other ways, many different backgrounds to come together and agree on that thing. But it is not the most advanced thing. The most advanced things go far beyond the guidelines. They have been doing that years ago, and they are doing far more things now. And they drop the guidelines for us to use. So yes, and so this is just a milestone to prove that intervention in stroke patient is stepping forward, and I believe that it will change in 5 or 10 years. Up to now, there will be many changes as this. Yes. So now we are proven, it is proven for us that if we select the patient carefully, if you identify the subgroup of patients right, we can open the vessels for patients up to 24 hours from stroke, and still we can save a part of the brains of the patient. Now we are waiting for more milestones to see how far we can go. But this is not the end. This is just a part of the way. So, yeah.
Yeah, I hope that those who watch this discussion over here, and those who practice in medicines get what Dr. Tuấn says, because when I was a student in the med school, we just follow the guideline and follow what the treatment approved procedure that has been published. I don't know how many years in the past, and we are afraid that if we go out of that, then if something happens, then we get scolded or get yelled at by our supervisor or superiors or the boss. But actually that's how medicine is happening around the world nowadays. It's changing very fast, and if you're the specialist in the field, then the trend is, we talk about that a lot during the conference. If you follow that, then we know that how things going on in our field, the trend. And if not, then when study like that's coming out, then they adapt and they change very fast. I think I gave this as a sample in the past, but just says again over here. There's a time with when the medicines Zygris is given for people in ICU for septic shock. We believe that it's help, but when a well-designed randomized controlled trial came out that showed that it's not really beneficial, it's off the market just within a few days. So that's how medicine committee respond to the treatment, and the pharmaceutical company respond to the new information. So hopefully with this journal clubs, we have the movement that people read new article, discuss the research, and change the practice accordingly to the evidence, so that our patient get the best benefit that they should have. Okay, so let's talk a little bit more about the research so that we can come home with some take-home message. Let me share the screen so that we can talk about one thing here. So this is the screen. Oh, can you see my screen? Where is it? It disappeared from my screen here. So on this table, it shows that, let's look at the table here. So it showed that the table B here. So it's compared two groups that people come from 6 to 12 hours and more than 12 hours. And we can see that, even though there's a benefit is there in the treatment group and the control groups, but you can see very well that if patient come early, still the benefit is still much better than if the patient come late. Even in the control group, 12 hours, like 7, those who recover well is still much more significant than those who's come late. So again, we cannot press harder that if someone know or suspect of stroke, come to the hospital where they can get treatment as soon as possible. Dr. Tuấn can help remove the clots 12 hours, 24 hours after the stroke happened. But if you come sooner, if he can perform the procedures earlier, it will be the recover, the successfully recovering is much better. And just last week, I have a patient visiting New York, and she had witnessed stroke just and came to the hospital just 2 hours after the stroke, and she received treatments, get the clot removed, and she recovered beautifully. She's back to normal right now. So that again, that's the importance of coming to the hospital as soon as possible. Don't have the phones feeling that okay, now today we can do something within 24 hours. So take it easy, just take time. No, it's not true. Still, come as soon as possible is the key. It's the key.
That's the key. So 24 hours is for physicians to do more for the group of patients that we haven't been able to do anything before. But it's not for the patient because time is still brand, When it's got an occlusion and the patient is having symptoms, that means the blood to the brain is not enough. So time is still brain. It is just that if you have no collateral, if you have nothing else to support it, then the brain will die sooner. The brain will die more in 1 hour than when you have collaterals. So time is still brain. The less time you take to open the vessels, the less brain is damaged, and the higher chance for the patient to recover. So it is not time for doctors or for patients to take time, because we don't have time to take. We don't have that much brain to take. It is just that we now can help patients, more patients that comes later than 6 hours. Now we can still do something to hope that we can change the way that they recover. So it is not for us to take time. Now we extend the time to 24 hours, but it's not for physicians or patients to take time. It is not that. It is for us to treat more patients, but time is still very, very important. When you are struck, get to the hospital as soon as possible and urgently, because it counts by seconds and minutes. It is not counted by hours, because if patients come to the hospital in the first hours, 90% of them will recover beautifully from stroke. 90% of them. But if they come later than 3 hours, only 50% of them can recover. So don't think that we have more time to wait. No. Okay, we don't have any more time to wait. We just have more patients to treat. We don't have any more time to wait. Okay. Yeah, but I'm glad because it proves that the technique is more and more safe now. It is not more effective because the way that you open the artery is the same, but now we can do it with shorter time and with less hemorrhage, with less complications. Yes. So again, everything is related to time. So for physicians too, because I told this to all the doctors that come to my hospital to learn about thrombectomy. It is not thrombectomy that works. It is a system that works. It is us as a team to detect the patients as soon as possible, to have a CT, MRI as soon as possible, to detect the vessels that is occluded as fast as possible, and to treat the patient as fast as possible. It is time. The faster the team is working together, the shorter time we can spend to evaluate and to get patient to treatment, the better the result. So 24 hours is for a subgroup of patients. 6 hours is for 90% of patients, but it is not for one patient. It's not for an individual that is having stroke. For an individual that is having stroke, time is all that matters. So, and we don't know what is their limit on time. We know that there are patients that will not recover after 1 hour because they have no collaterals. We know that there are patients that can wait until 24 hours, but individually, we don't know who is who. So we don't know who is us. So we have to rush as much as possible. We have to be urgent as much as possible and don't waste any seconds that is not needed. So,
Can I add some more comment about what Dr. Tuấn just said? I can see the very fast of where I work in UMass. They have a system of STEMI that very well to recover a patient with heart attack, and the time consuming that they count from the first phone call to 911 to the time that the patient gets the intervention. So we have to have a system when they found out the victim, and the ambulance, they have to have a well equipment and equip a heart doctor that waiting, or the stroke doctor that waiting to help the patient. That's the time that we have to think about that. The system needs to be working better. Yeah. Not only like the time that the doctor spend with the patient.
Yes.
So we don't have that system in Vietnam yet. With all traffic jam, with all the equipment for the ambulance, we don't have that yet. So that is the message I have to send to the doctor in Vietnam.
Mm-hmm. Yeah.
Not only the doctor in Vietnam in hospital.
Yeah. It's not just a doctor, the whole system, and traffic. Or I don't know. I just got a post from my friend that he was in the ambulance, and it just cannot get any privilege and get no priority to go through, and that's real pain if you have your family in that same ambulance and in the traffic jam and no one willing to give way. It's really the pain, and there's a lot of things need to be changed to get time from stroke, witness stroke, to needles, at least from the time they hit the door. At least there's a lot of things need to work together to have things that fall in place.
Yes, that is why we are trying to have as many hospitals doing stroke as possible. Because the traffic is something that it's very hard for us to intervene with the traffic with a large scale like that. We know that paramedicine is very important in trauma and in stroke. We know that because it's urgent. When it is urgent, the patient have to be transferred to the hospital as soon as possible. Now, traffic in Vietnam is something that is too big for us to deal with. So we have to, when we deal, we talk with the 115, and 115 it's like 911 in America. The emergency ambulance service. The emergency ambulance service is now separated into a separate system, and they run by themselves. And it helps because as they run by themselves, they are having more and more more and more places to place their place their ambulances, and there are more and more available for patients all around Ho Chi Minh City, all down the region. Okay, now we have more and more hospitals to do the job. That means the patient have more choice. They don't have to come to Charai Hospital, they don't have to come to University Medicine Hospital if they're too far from that. Mm-hmm. They can choose the more hospitals that can do stroke. Then the more chance for the patient to have a hospital next to them to come to the hospital as early as possible. Mm-hmm. And in the province too, in the countryside, we are having more and more hospitals that is trying to do stroke. But again, it is developing here in Vietnam, and it will take time, at least 5 or 10 years, to have a rather good, managed system in the hospital that is now trying to do stroke. So we want to rush that. We want to overcome that. We know that paramedicine is very important. We want the patients to have more chance to have nearer hospitals to come when it comes to stroke. But we have to deal with the truth, with the risk, with what we are having now, and it will take time. For example, if with hospital that is now trying to do stroke, it will take you 2 years. It will take them 2 years, 5 years to be master what they are doing. Mm-hmm. and to run as fast as possible. My hospital too, when we do stroke, it takes the patient 2 hours from detecting in the emergency to the DSA room. It takes 2 hours because it takes 15 minutes each step, because physicians doesn't get the reflex yet. They have to stop and think what they are going to do next. So it takes 15 hours every step, and for 6 or 8 steps, it becomes 2 hours. Now it's only 30 minutes because now we do without thinking. So with time, when the physician is doing stroke, becomes more familiar and they build a reflex in themselves on what is going to do without too much thinking, things will be better. So we cannot do the best now. No one can. And even in centers that are the best now, they are always trying to do better. So what we're trying to do is to get better with time. From year to year, we have more and more hospitals that's doing stroke, more and more physicians that's doing stroke, and just doing things faster and faster. And we have more and more charge for the patient, more and more better and better paramedicine with 1.5 ambulances for the patient to get them have a higher chance to get to the hospital. We cannot be the best. We know that because we're in the developing countries. But I believe that we're progressing rather fast compared to the common stages of surrounding area countries. And we are trying to progress faster based on what we're trying to do now. We are trying to have more and more physicians, the next generation, to come in this, and we are pushing them to go to conferences, to go out and talk with patients around the world to know why is it so important for patients there. But it will take time. It may take generations to change the way the people is thinking and to build a better system. And we are still trying, and we believe that in the next years to come, we will have a better and better system with time. And I think that's the most matter, and what matters. No matter how good we are, we will still have patients that we cannot treat. We will still have patients that we will feel pity about. But I got that feelings too. But because of that, we got to have a better system with time. And we cannot have a better system by telling the physicians that you're not doing that good. We cannot have that with that kind of attitude. But we have to realize that what we're not good now, and I have to kind of boosting them by putting some energy in them, by telling them that we can do better, not telling them that you're doing a bad job. So with our situation, with our system, I think that it's better to try doing better with time and give them energy for doing that. Yeah, but I want you to know that.
I know. I have been working in Vietnam for 20 years. I think that we can count on young populations. They're very fast with the iPhone. So I advise my family member that you have to know which way is the faster to bring your family member to the hospital. Because you traveling every day, you know where is the traffic jam. And if you have to figure out when have anything in emergency, you have to figure out the way and show the 115 where they can go faster. Or even you have to go with them. That's why I tell, because not the doctor not doing good job, the population. They count on doctor and don't donate nothing.
Okay. I think that we spend a good time discussing. Maybe for our last few minutes, we got to wrap up and let Dr. Tuấn have his Sunday with family. Any take-home message from Huong? You want to give your take-home message when you read about this study and do your reading? I know that you spend a lot of time and effort onto this. So, one or two take-home messages from this, what you learned.
I haven't thought of this before because I dig so much into the design understanding. But I think that after a very thoughtful discussion, we have just been through, the very first take-home message is time is precious and time is brain. So it's not really depending on whether you have the thrombectomy or not, we still have a worse result if we receive the standard care in late representation. So on and on situation, try to seek for medical help when you suspect of stroke symptoms in any person or any patient, and maybe this will be the of patient education role for us as a medical officers, and also for we have to be aware of the role of patient education in such situation. Like we know that the time for them to receive treatment is very dependent on the time they can seek medical help. So this is the first take-home message. And the second one, I think, is for patients who has daily practice of meeting patients with stroke. So thanks to the results, they will learn that there's another way to save the patient's life, or to help them to have a better recover, better quality of life after stroke, if they can help to transfer patient to the unit that can perform the even if the patient has arrived late, arrived more than 6 hours after the onset of the stroke. So maybe it's still a better way to treat the patient. So if I was the primary physician, and when I learned the information in this from this research, I will consider like prepare my patient better, or transfer my patient to stroke unit for them to maybe to benefit from the thrombectomy if possible.
Okay, thanks you. Yeah, I just from your part, I just have one quick. My take-home message is sometimes I receive call from my patients asking, hey, I'm having this, having that, what should I do? Maybe I'm gonna be more aggressive to again educate them if they have symptom of stroke. Don't have to confirm that a stroke yet, then just go to the hospital as soon as possible. Then it's better and safer for them. And even if they say that okay, it's just have some symptom like when I wake up in the morning, it's just still rush them to the hospital as soon as possible, because new technologies can help objectively find out whether the chance to do interventions can help their life. Because before this, from what I remember from study medicine, just okay, if you wake up with stroke, then there's like not much hope to come to the hospital, but not that in that urgency. But now I know that it's still really, really urgent. Time still matter, no matter whether you have witnessed stroke or wake up with stroke. So that my hope. But it's one thing that's for the politics over here, not politics, but the situation in Vietnam over here. I don't know. And how's your workload? If more patient now, you have like more patient to treat, is that affecting you? If you are in the room with the patient have 24-hour stroke, and now another one hit the door with like 2 hours witness stroke, how are you gonna do that? You have resources ready for that yet?
Yeah, we're now having 2 doctors that can do that, so we can handle 2 or 3 strokes at the same time. And we are having 2 DSM machines. So if the patient, we used to have 3 consecutive strokes at the same time.
Oh, okay.
So it's not always like that, but there are times that we have to select, just like in the disaster. Then if you have too many stroke patients at the same time, then it is it will make it more complicated, because now you have to evaluate and to decide which patient you will treat first based on your prediction on what patient will be more benefits on their treatment, will be have more chance to recover from your treatment, and which is not. So it is hard to tell because we don't have criteria for that. But if the pain is more than 80, if the patient have a larger area of infection, then probably we will be more careful on treating those patients. And if we have younger patients with a higher chance for recovery, we tend to treat that patient first. Because I know that it is problematic, because but we have to face with that. we have when we have too many patients to treat at the same time, we have to decide based on what we have that which patient will probably be more beneficial for treatment or not. And now it becomes subjective, you know. It is kind of objective because you have to agree among the team on which patient to treat first. But it's still subjective because you cannot be sure about that. But again, you have to deal with that, and that's how we're dealing. It's good that we're working as a team, so that when I walk inside, there's a room. There are doctors, neurologists outside to think about that, discuss with each other, and decide that for me. So. But we don't have that much patient. Very usually we have one patient at a time up to now. So with this change in the data, we expect to have more patients. But again, it is not easy to apply this data in Vietnamese condition, and we are still struggling to apply that in the right way. Because it is easy to have the clinical data of the patient. It is easy to have diffusion and MRI, but we know that even the part on diffusion on MRI that we think is infarction, it can still recover in some ways. So it sounds easy, but it is in fact not that easy to identify the area of infection on imaging. You know, it sounds easy, but if you identify it on CT perfusion, for example, you will identify very clearly the area of infection. But there are areas that infect, but you don't know on CT because there's still blood to there. And on CT perfusion, if there is still blood to that brain, to that area of the brain, you consider that it is still alive, while it may not be alive because it can be infected because the blood flow is there, but it is too little for the brain to fight with that. On MRI, you can overestimate, and most of the time we overestimate the area of infection on MRI, and we underestimate the area of infection on CT. Now, what we want to do, now we never have the exact answer on what area is the real infection area. We never have that. So it is easy. It sounds easy when you read trials. But when it comes into practical, it is not that simple. It is not that simple anymore, because now how can you define the area of infection? Because the area of infection in MRI can recover, and the area of infection on CT can be larger than the area that you think. So that is why we have to build. We have to find something in between. And we have to build, we have to discuss with the team to agree with each other what we are going to do, what we're going to use. And sometimes we have to try CT perfusion. And if there is problems using CT perfusion, we have to try MRI. Okay. Also, for example, practically when you do CT perfusion, it will not take you so many time because CT is fast. If you have MRI, you have to have the MRI team there all the time, 24/7, and you have to open the machine, you have to run the patient, you have to run the protocol, you have to have time for them to do the job faster and faster, because the first cases, the first 5 cases that they do will take time and will elongate the time for treatment for the patient. So it is hard practically to apply something new in practice. It sounds simple, but when you want to make it practical, it may take you months to make it a routine practice. And when something new comes up, now we have to try to change with that too, and it will take months to do that. So it's not easy. It sounds.
Yeah, it's not easy as it sounds.
But we have to do
but we keep trying. Yeah, I think this is a bit late, so I just have 2 last comments. One is, yeah, again, it's easy. I'm not working inpatient anymore, but I remember during my training just like 6 years ago, the hospital that I had my training, of course we had MRI machine, but until that time we don't run MRI. We didn't run MRI at night. So yeah, so it's for this kind of situation, patient hit the hospital at night time, have the stroke, then CT is the only option we have. So I think, I don't know, it's on a change. Maybe it's changed by now. So that's one thing. The other things, just for us to think, you don't have to give the answer yet because we don't have a lot of time. But I don't know how patients gonna take it, given the situation that a little bit about more violence in our hospital nowadays on a newspaper. If like family or patient, how they perceive the result of this article, if they become more publicly aware of that, then they're gonna pressure doctor to do more intervention to them because they think that, okay, it's gonna help the family member recover better. So more pressure for Dr. Tuấn maybe to do the intervention for my father, my mother, whoever, because it showed that 24 hours still have hope. I don't know. It's gonna change the patient perceptions about doctor taking care of them or not. I hope that if someone gonna gives like patient educations, I hope that we keep pressing more about time, and also show patients and family or general population in general that the table I showed earlier, that yeah, even with treatment, even with doing whatever we can, 50 or 70% we still have significant deficit, even after what we do whatever for them in this late population. Yeah, so right. Hopefully we can do something to educate our patients.
Yeah, I got a very you may all know that I got a very bad experience on this when the patients does not agree with the result. So my way of doing that is to get in the consent form. I have a very specific consent form for any kind of disease that I'm treating with the patients. In that consent form, I have all the details that I will talk, and I have talked to the patient before on how I will do the procedure, what is the complications that may happen, what is the prognosis that we may have. For example, with stroke, on that consent form, I got a 5% of hemorrhage complication. I got a 10% of death because of the disease still progress no matter what we do. I got a 50% of chance for the patient to recover, and another 50% of them not recovering after that. From 2 years ago, when I begin to use those consent forms, things will become much easier, because now the patients know, because they cannot forget that. I give them one consent form for them to read, and one consent form for them to write, and the one that I give them, they keep so that their families can read that. So now they know for sure what they're expecting. I think that the most does not know very easily on what they are expecting and what they are facing with. So even after we talk, they can easily forget that because they're not expert. Mm-hmm. The medical student, they can still forget that because
oops, we lost him. Oh. Okay, I'm sorry, we lost him. Oh, okay, he's back.
I'm sorry, maybe because of the internet. Yes, but I want to share with you how to avoid the disagreement between physicians and patients' families. Well, I write it on the consent form because I realized that even after half an hour sit there talking with them all about the details of the procedure and of the disease, many of them still forget that because they don't have the background to understand and remember that. I realized that when I talk this with the medical students, they will still forget that after several days. So how can I expect the patients to remember that when they're not in the medicine, when they're not doctors? So I overcome that by writing it down, printing it down for them to read from day to day so that they can understand all that. So from the time that I use that consent form, things becomes much easier for me. They know and they don't ask too much of why the result is not as good as we think or not. Because they read it from time to the data, they have the number on there, and they know that there are a chance for the patients to recover, and they also have the chance for the patient not to recover, and there are 1/10 of the chance for the patient to die because of the disease. So with diseases concerning the brain and diseases concerning the heart, for instance, I think that kind of consent form will help us very much. So patient education is very important, I think, and as educating a medical student, they need printed layout. So does patients. They need something that they can read, something that remind them of what they have been taught about.
Okay.
So
yeah, it's very, very important point. Not directly related to our article, but it's very practical in our daily practice. Especially in those life and death are really affecting patients' quality of life and condition along the way is really important. All right. I think that we got to wrap up and let everybody have enjoyed the Sunday. I thanks Huong Trần for taking the last minute request to prepare this article and do it very well, especially the hard work of look up all the information and doing the methods. I do learn a lot about the method from this study, and thanks, Dr. Tuấn. You always there when we ask and try us, and willing to spend 3 hours plus of your precious Sunday with us. Hopefully, we don't ask you to try it too many times, but that's very very interesting and very very interesting discussion, and we really very happy to have you share with us your experience, your daily practice, and your even the consent form, for example. Very very valuable to learn, especially for young doctor who start their career. Because one bad experience may really set you back and make you reserve and not see patient in the same way, and it's really unfortunate if that happened. And thanks everybody, thanks Yilang, and thank everybody to follow to the last minute here. We had spent like 3 hours straight, and hopefully we can have more discussions about more topic in the future. And then you have last last word for us.
Yeah, okay, thank you for having me. And don't worry, because it is late. I tell them that I won't take them to the swimming pool, but I will take them to big fun. It is even better for them, so they are very happy.
Okay.
Yeah, so next time if you need, I'm more willing to join, because I like this. I like talking and sharing experience, and because I'm really struck, the more people know about this, the better. So if you need me on these kind of activities, I'm more willing to join. Okay.
Thanks.
So wish everyone a good Sunday.
Thank you, Anton. Thank you, everyone. Wish you all have a good weekend, a good Sunday, and thank you, Huong. Okay, this is the recording. The second part of the discussion is recorded. I will try to upload. I still